The third area that states are focusing on, try to get the next slide. Focusing on is reducing overpayments before they occur. Today, most payment recapture or overpayment programs tend to focus on maximizing recoveries. If you ask most managers that are responsible for payment recapture programs, one of the first things they talk about is how much money they recover each year. As long as that number is going up, people are happy. But with the focus on payment recapture programs by both Medicaid agencies and providers, there's a unique opportunity to move beyond retrospective overpayment recoveries and truly being a driving force in prospectively preventing overpayments before they occur. Preventing overpayments before they occur is really the holy grail of any payment recapture program. So in addition to talking about how much money was recovered retrospectively, you can also talk about how much money you saved by preventing the overpayments. The reality is that healthcare billing and reimbursement is a complex endeavor, and providers and payers with the best intentions and the best processes will still have overpayments that need to be identified and recovered. The goal really is to ensure that you have identified and recovered as many overpayments as possible, but that you've also prevented overpayments from occurring. The key to preventing overpayments from occurring is to be able to quantifiably measure what is causing the overpayment. The 60-day rule requires that providers describe the cause of the overpayment. So the opportunity here is to create a standard list of overpayment codes that providers are required to use. Standardizing the root cause list allows you to capture and track information so that it can be easily measured consistently. Once you know what's causing the overpayments, you can implement corrective action plans that can be measured and quantified. For example, if you see that 18% of your overpayments are because the MMIS paid more than the coinsurance amount for a claim with TPL, you can implement corrective actions and then measure the effectiveness of those actions to see if they reduced future overpayments. Again, you're never going to be able to prevent all overpayments from occurring, but the faster you can identify the overpayments and implement fixes and measure whether or not those fixes worked, the better off both you and the providers will be. So what are some of the initial steps you can take to optimize your payment recapture process today? First, inventory all of your overpayment projects, including projects performed by different departments in your state and external projects that are being performed by outside vendors or contractors. Are there any overlaps in terms of claims providers? Is there duplication? See where the gaps are. Are all providers types being reviewed in some fashion? Are all claim types? Some states focus on high expenditure providers such as hospital, long-term care facilities, and pharmacies. But in aggregate, the smaller dollar claims can be significant in terms of expenses, so make sure that they're reviewed also. Next, review the payment recapture process itself. Is it consistent among providers? Are some providers using electronic refunds and some using paper? Are there one-offs in the process? One-off processes are common in special projects, and vendors may use their own processes. Can these be eliminated or reduced? How can the process be streamlined by using easily deployable and efficient technology? Then review your data. Are there opportunities to improve how the data is consolidated? Is the information captured consistently? Can you easily identify all of a provider's refund activity across multiple projects? Can you identify which providers refund consistently and which don't? This type of information should be easily accessible. Finally, most importantly, open a stakeholder dialogue. Talk to the various teams or departments in your state that may be facilitating payment recapture projects. Do they have best practices they can share? Is there a mechanism to prevent different initiatives from refunding the same claim? You compare initiatives and work plans to make sure that providers aren't overly burdened. And also engage the providers because they're important stakeholders. Providers are a great source of information about the payment recapture process, what's working, what's not working, and how things can be improved. So in summary, I'd just like to encourage you to take the opportunity afforded by the 60-day rule to review your current payment recapture process and identify areas that can be improved, especially with respect to streamlining the process and utilizing the data to not only maximize your recoveries, but also drive improvements to minimize future overpayments. With that, I'd like to turn it over to Kim.
Thank you, Kevin. As everyone knows, states can't rely exclusively on providers to detect and disclose all overpayments. Most states have many provider audit and review programs in place to identify and recapture overpayments, but oftentimes resources are limited and thus the opportunity is not maximized across all of the services provided. Now let's discuss what healthcare reform says about Medicaid recovery audit contractors, better known as RACs, and how RACs can be a part of the state's comprehensive overpayment solution. Just to make sure we're all on the same page, let's review the actual RAC requirement of the Affordable Care Act. The provision calls for states to contract with a vendor or vendors on a contingency fee basis to identify and recover overpayments, and underpayments. As some of you may be aware, CMS issued a state Medicaid director letter on Medicaid RACs back in early October, and they also conducted a brief webinar yesterday for the states to further clarify the directive around the RAC. As most of you know, CMS first started the RAC program back in 2005 with Medicare RACs in 3 states, Florida, California, and New York. The Medicare RAC pilots focused on the identification and recovery of overpayments mostly found through reviews of medical records. A large portion of overpaid claims were due to whether the care was medically necessary or delivered in the appropriate setting, and therefore covered under Medicare payment rules. Though the program caused provider concerns with respect to the vendor requirements and protocols, the contractors reportedly recovered $900 million in overpayments nationwide resultant of this pilot. In 2007, the Medicare RAC process was rolled out across the country. As a means to identify fraud, waste, and abuse and help fund health care reform initiatives, the Affordable Care Act included a requirement that the RAC program be extended to all state Medicaid programs. There are, however, many important differences between the Medicare RACs and the Medicaid RACs. The most important and the most significant difference, of course, is that unlike Medicare, Medicaid programs are state administered. For this reason, CMS is allowing for flexibility in how states design their RAC programs. CMS also recognizes that states already conduct several types of Medicaid audits. These audits are done by the Medicaid agencies and divisions internally, the Medicaid fraud units, the AG offices, the HHS Inspector General Office, the CMS-administered Medicaid Integrity Contract, and through supplemental vendor efforts. States must ensure that all of these complex efforts are coordinated via a very customized RAC approach. Can you go to the next slide? Thanks. Okay, so let's take some time to review some of the differences between Medicare and Medicaid RACs. The obvious difference is that there's one Medicare reimbursement policy, while each Medicaid program has a complex, unique set of payment rules and protocols. Perhaps the biggest difference between the Medicare and Medicaid RAC contracting processes is that CMS actually directed the Medicare RAC audits. The Medicaid RAC will be a state-directed program. CMS recognizes that the states have the direct relationships with the providers of care in their states, and that each individual state has a unique MMIS environment. Since each Medicaid program has a unique claims payment system, it's very important to ensure that state vendors have experience working with and reformatting MMIS data. Another key difference is that for Medicaid RACs, the states must collect the overpayment from the provider and return the federal share of the overpayment back to CMS. In the Medicare RAC program, vendors do not actually collect overpayments and handle cash. They send the overpayments to Medicare administrative contractors, the MACs, for offset processing. Finally, there's an extra level of appeals related to the Medicaid RAC. After the provider appeals to the state can actually appeal to CMS. From a scope of work comparison, we should note that Medicare RACs were focused primarily on hospital clinical reviews. The intention of the Medicaid RAC is to leverage a much broader and robust audit program. In fact, some states have already reached out to CMS and been given the feedback that CMS is not likely to approve a RAC that does not take into account services such as home health, hospice, DME, long-term care, and certainly the home and community-based waiver services. As states design RAC programs, they should carefully consider including these services as part of the RAC solution. All in all, the differences between Medicare and Medicaid RACs provide states with an opportunity to design a program that complements rather than burdens a state's current efforts. If administered properly and with contractors who understand the Medicaid environment, the RAC contracts should be able to help offset some of the costs Medicaid programs will face down the road due to the projected increases in Medicaid eligibility and enrollment resulting from federal health care reform. There are several ways to benefit from your RAC. The RAC provides states with a vehicle for adding additional oversight to the claims billing and payment processes without adding direct upfront costs. The RAC provides an opportunity for states to perform a gap analysis across all Medicaid state plan and home and community-based waiver services. States should look at their current internal and vendor overpayment audit programs with a very, very critical eye so as to fill in the gaps. The RAC contracting vehicle allows this option to look for and leverage best practice technologies and processes that a single state could not afford to build out on its own. Vendors can oftentimes invest in best practices and provide solutions to identify overpayments because those investments can be leveraged across multiple clients or states. One example of a RAC audit-like best practice focuses on conducting a review and data match across all payers' paid claims transactions. In essence, a state could secure years of paid claims transactions from Medicare and commercial carriers and match those paid claims to their own Medicaid paid claims data set. This match could result in the identification of duplicate payments paid to providers as well as overpayments made to providers for beneficiaries who are really balance billing the Medicaid program for their cost-sharing obligations. Consider in this just one example of how costly, both from a time and money perspective, it would be for a single agency to secure the paid claims from each of the payers contracted with each of the providers licensed and credentialed to do business within that state. So the biggest challenge states are facing, and a question that we often get asked is, well, how do I design the scope and structure of my RAC program? What services do I include? What if I already have robust audit programs in place for various providers and services? Well, let's take a few minutes and try and dissect this. Remember, RAC is a state-directed program. Each Medicaid agency has a unique opportunity to create a complementary program that pays deference to those current baseline audit efforts while creating new audit programs where it makes sense. Let's talk about a few examples of how states have already approached the creation of a RAC program. At least 8 states, to my knowledge, had existing program integrity, contingency fee, RAC-like vendor contracts in place prior to the Affordable Care Act to identify, to validate, and to recover Medicaid overpayments as well as provide the full appeal support. Many of these states are currently filling out their RAC state plans, the RAC state plan amendments to reflect the status. Many of these states are also performing gap analysis to refocus their current vendor as they formalize these existing efforts into a CMS compliant RAC holistic solution that addresses all Medicaid covered services and the home and community-based waiver services. At least 6 states have already issued competitive procurements for a RAC or a RAC-like audit program. This includes 1 Northwestern state, 2 Midwestern states, 2 New England states, and 1 Mid-Atlantic state. 1 state excluded institutional services from the scope of work. Another included at-risk encounter claims, while another excluded those same at-risk encounter claims. And finally, another state asked that the bidding vendors provide a technical approach and qualifications for every Medicaid and waiver service that is part of their program. In each of these procurements, the state is directing the RAC solution so as to build a complementary program to their existing state efforts and program goals. In all but one of these procurements, the Medicaid agency requested both clinical and financial audit services. Only 1 RAC-like RFP so far solely requested financial audit services. In each of these examples, scoping the RAC program provided the state with a great opportunity for ensuring that claims are paid correctly. And in the end, it's really be left up to the state to determine what to include or exclude as far as claim types and audit processes.